I want to thank SAGES for letting us present this work on a podium. I want to give a shout out to everyone back at NYU Langone Health, those who are covering our shifts right now, Dr. Chiang, UNZ, our statistician, our informaticist, physician informaticist, Nilfar Tursunova, Jane, our medical student, and Dr. Ferzli for sponsoring this work. I have no disclosures to disclose. So if you query the room, if you query any bariatric surgeon, they'll tell you there are a multitude of ways to achieve what we see in the right side of this picture, the sleeve gastrectomy. And we know it's an effective way to address morbid obesity here in America and also in Canada internationally. If you look at survey data, nationally, internationally, there's a huge diversity in technique. And so how do you study this diversity technique and how it affects outcomes? There have been previous attempts. A retrospective study in 2018 did show none of the variations in technique really predict perioperative morbidity. 2019, another study showed that it's safe and effective. Really, the techniques variability don't affect safety. How else do you study technique? There are a litany of cohort studies that look at stapler technologies and bougies and leaks and how do you test it. There's even Delphi consensus statements from a lot of people either sitting in this room, attending this conference to describe what the critical steps are for a sleeve, but the bottom line is we still don't really know what's right. So, very controversial. Our unique approach was to compare our own surgeons within the same system. We have 3 accredited bariatric centers here at NYU Langone, one in Manhattan, one in Brooklyn, one in Long Island. What that means for a lot of you is MBSA QUIP. We are a part of that initiative. We are held to standards of safety and quality, and we routinely give our data to a data registry and reporting, and we get that fed back to ourselves. So what does that look like, really? This complication data is bleeding, surgical site infections, morbidity, mortality, readmission rates, reoperation rates, and within morbidity, we see postoperative nausea, vomiting, DVT, PE, so on and so forth. So all 3 of the 10 surgeons from the 3 different campuses, they contribute regularly to this MBSA QUIP, registry and database. And so this gives us a great opportunity to study the effective technique. What we did was we took all patient data from 2017 to 2021. We looked at the MBSA QUIP 30-day follow-up, and all 10 surgeons were queried on how they do their sleeve gastrectomies. And this is all based off a Delphi consensus. Somewhat of an issue, but just based on the inherent design, we were limited to univariate logistic regression, and we looked at the surgical techniques and their effect on adverse outcomes. What techniques did we talk about? We chose to talk about approach, whether it's robotic, laparoscopic, bougie, buttressing, oversewing, staplers, hemostatic agents, and whether or not you do an entrectomy, how do you manage a hiatal hernia, how do you manage postoperative GERD, and whether or not you routinely use preoperative EGD or upper GI series. And again, what we did was that we compared that to their, adverse outcomes and mortality, morbidity. We broke it down to technique. We're going to show you the results right now. And our informaticists also constructed very, very good literature search strategies for each technique, so we can see how our outcomes compared to what national data or international data shows. What that means, again, is that we did each one of the 11 things that we asked here. They made a very thorough search strategy. We all went through all the data on our, with a fine-coat tomb, and we looked at it. So if we look at the approach, our surgeons, if underwent laparoscopic, had lower total adverse outcomes, lower bleeding rates. If you look at meta-analysis data, it should show that robotic and laparoscopic approaches pretty much are equivalent, and that there's a question of how much does it cost. Maybe it increases time, maybe it's, there's an issue with haptics, but, specifically with our data, this probably is explained by surgeon experience, learning curve. A few of our surgeons had only picked it up since 2020, so this is possibly why we have this outcome. Bougies, using a 40 French versus a 36 French, our surgeons saw lower total adverse outcomes, bleeding rates, and readmission rates. using a VCG rather than a reusable bougie had less SSI rates. The bottom line is, based off the literature search, there's no consensus on bougies. There's a thought that maybe if it's smaller, there's weight loss, better weight loss, and if there's larger, there's less complications. But again, just there's no consensus on bougie. When we look at staplers and stapler types, there's no difference between Covidian or intuitive. Now, granted, the intuitive stapler loads were mostly the robotic, so that there's a confounding bias there. In general, there's a paucity of high-quality studies that really compare linear stapler brands and then like what's the ideal staple height. There's quite a few high-quality studies to demonstrate that shorter staple heights might actually lower bleeding rates. Use of staplers and buttressing. If you buttressed in our group, you had lower total adverse outcomes, bleeding, and readmission rates. Buttressing remains controversial. Meta-analyses show that, it was 2013 showed that it was ineffective, and in 2016 it actually showed that reduced staple line bleeding and overall complications, but not leak rates. So again, the jury's still out on buttressing. Oversewing actually had a lot of data on it. If you oversewed in our group, you actually had a higher total adverse outcome, bleeding and readmission rates. There's a thought with some clinical trial data that this, when you oversew, you might actually cause some postoperative nausea, vomiting, and decreased oral intake in the immediate perioperative period. But if you look at 2020 and 2022 meta-analysis data, there's some evidence to show that it reduces complications, for example, bleeding and leaks, but not really sewing. If you look at 2016 meta-analysis data, it wasn't better than buttressing and basically showed similar overall complications, but prolonged the operative time clearly because you have to do the sewing. Hemostatic agents was interesting. If you used a hemostatic agent, you had a lower total adverse outcome and bleeding rates, but you also had higher SSI and reoperation rates. If you look at 2021 meta-analysis data, if you use hemostatic agents, of course, you decrease the incidence of bleeding, but this was somewhat comparable to oversewing. So if you oversewed, it was very similar to using a hemostatic agent. So how do we explain this? Maybe it's a nidus for infection. There's a question of, when you use it, there's a cost, but also it's confounded. Maybe our surgeons are using this with more difficult cases when they encounter bleeding, so maybe this is why they're getting, higher adverse outcome rates. Stable line proximity to pylorus. Now we're thinking about entrectomies here. 3 centimeters from pylorus versus 4 to 6 centimeters had lower total adverse outcomes, bleeding and readmission rates. Again, this is more of a balance between leaving enough of the sleeve to have, to reduce leak and symptoms, but taking enough of it to have weight loss and, to help fix diabetes. Meta-analysis data shows that there's no effect on leak rate or weight loss, and similarly, entrectomy might have sustained weight loss and really no impact on postoperative complications. Routine upper GI and EGD. If you did routine upper GI series, you had a higher total adverse outcome and bleeding rates. Routine preoperative EGD had lower SSI rates. Question is this uncomfortable and costly? Is it a barrier? We know that a lot of our patients have barriers to getting bariatric surgery. Finally, hiatal hernia management. So sleeve, if you did a sleeve and you identified hiatal hernia before this, before you took the patient to the operating room, you actually saw higher bleeding events. Prior studies have shown that you probably could do a simultaneous sleeve and hiatal hernia repair if it's safe, if the hiatal hernia is small enough. There's still a long-standing debate on this. So lots and lots of data in an attempt to study it in this fashion. It's retrospective, it's univariate statistical analysis, so you really can't control for interaction. Also, you can't really separate the surgeon's experience from the type of technique that they do. The sample size is small, the follow-up data for 30 days was limited by MBSA QUIP. And if you aggregate the data based off of surgeon data, you're sort of like losing out on the patient demographics. So do all roads lead to Rome? This has never been done before. Some of this is interesting results, but it's cautionary. We give this with caution. There's a lack of consensus on techniques, surgeon experience. Obviously, preference plays a role in outcomes. We hope that, accruing some more data can help us refine this model. We can apply more Delphi consensus techniques, like how do you manage leak, or how do you test for leak in the operating room, and perform prospective studies on things that we suspect are different. And we already did this same thing on Roux-en-Y gastric bypass, and we presented it on Thursday. So again, I thank the moderators. I thank for SAGES for letting us present this big work here at NYU, and we'll take questions now.